75 men admitted to the hospice care for end-stage multiple myeloma. He has severe pain due to pathologic vertebral compression, fractures, and osteolytic rib lesions. The pain remains uncontrolled despite continuous IV infusion. Infusion rate has been increased several times, most recently 2 days ago. Temperature fine, pulse is high, no, sorry, BP high, pulse normal, respiration low, pulse oximetry is 89. On exam, the patient is drowsy but constantly moans in pain and opens his eyes when his name is called. Which of the following is the most appropriate next step in management of this patient? Hmm.
Okay. So this patient with end stage malignancy has transitioned to hospice care, in which uh, the focus shifts toward maximizing comfort, pain control versus extending length of life. He has inadequate pain control despite his current morphine dosing, and has evidence of sedation and respiratory depression, respiratory rate less than 12 per minute, less than 12 per minute. For patients with terminal illness, advanced cancer, intervention that have been intervention that have adverse effects, respiratory depression, are justified if they are given with the intention of promoting the patient's well-being and allowing for comfortable death on doctrine of the double effect. Therefore, it is appropriate to increase this patient's morphine dose illness, in which serious adverse effects like respiratory depression uh, require opioid dose reduction and pursuit of the alternate pain control modalities. Okay, so we can increase the dose in if the pain is not controlled in hospice care.
Basically, you increase it until they die.
Yes.
That's crazy. I didn't know that. Okay. Next, 30 primigravida woman 10 weeks gestation comes to the office for initial prenatal. The patient has no chronic medical condition, no surgeries. While discussing what to expect during pregnancy and delivery,
What is the
the,
difference between hospice care and the palliative care?
mm,
In
I think
yes.
palliative care is a part of hospice care. It's just for pain, and you do it at the hospice care. I think. Let me see.
They have like in case of prognosis they have separate identity, like uh, in hospice care we provide the comfort and the support at the end of the life, but in palliative care manage symptoms and improve the quality of life. Like in chronic illness, like in cancer, we can give palliative care, and in hospice care there is a like prognosis, there is a call prognosis which is less than 6 months,
Mm-hmm.
and in palliative care there is no such time restriction, and in
Mm-hmm.
palliative care there is no curative treatment. We are giving like to control the symptom, like he this patient has pain and we are trying to controlling the pain, and in palliative care there is curative treatment, pursuit of there are some pursuit of curative treatment. Okay.
Okay. Primigravida 10 weeks gestation comes to office for an initial prenatal visit. The patient has no chronic medical condition or surgery. While discussing what to expect during the pregnancy and delivery, the patient stated that she would like a primary cesarean delivery performed. The patient mother has struggled for years with urinary and fecal incontinence after Having pre-vaginal delivery and the patient does not want the same complication, the physician discusses the complications associated with C-section, including the increased risk of complications future pregnancy. Based on the lack of medical obstetric indication, the physician is uncomfortable agreeing to perform the procedure. However, the patient states that she understands the risk and still wants a C-section. Which of the following is the most appropriate management of this patient?
What you want to do? Okay. Although cesarean delivery are medically indicated, breech presentation, fetal distress, and a small number performed on maternal request in the absence of maternal or fetal indication. After the risks and benefits of both cesarean and vaginal delivery are discussed, patients can choose their mode of the delivery. Physicians uncomfortable with performing a cesarean delivery on maternal request are not professionally or ethically required to perform the procedure. However, physicians are responsible for ensuring continuous and comprehensive care. Therefore, most appropriate management for this patient is an early referral to another gynecologist. Okay,
83 woman brought to office by her son as new patient. The patient feels well, no health issues. Review of medical records from her previous physician indicates that she has osteoporosis and cognitive impairment. The patient takes no medication, lives with her son and grandchildren, and is independent of with activities of daily living. She prepares meals for her family and plays outside with family, dog, and grandchildren for 20 minutes daily. Temperature is high, pulse is normal, BMI normal. The patient is alert and conversing and oriented to everything. Exam of the heart, lungs, abdomen, everything is normal. The results of the lab testing, including LDL
n-
170, tags, wait, let me check.
not that high.
LDL, yeah, is a bit high. Tags is, where am I? Yeah, it's high. And hemoglobin A1C is high.
It is
The
low.
physician diagnoses hyperlipidemia, diabetes, and home monitoring blood pressure is arranged. When discussing medication options for the patient, which of the following action is most recommended to improve healthcare outcomes and quality?
Extra-
Makes sense.
What does it mean? Okay, considering average time to therapeutic benefit as extrapolated from research studies.
What are you reading?
Oh, I'm reading the explanation. Okay.
Oh, okay.
Okay, first box. Medication prescribing in elderly patient. Medication prescribing the elderly patient. Major considerations. Major considerations. Increased susceptibility to adverse drug events. Increased susceptibility to adverse drug events. Increased polypharmacy risk due to multiple chronic conditions and susceptibility to harms from overtreatment and undertreatment. And principles of prescribing limit the number of the prescribers, review criteria for geriatric population bears, um, Beers criteria, list of medication considered potentially inappropriate or to be used with caution in elderly, consider time to benefit for drug, and tailor regimen to the patient's goal and life expectancy, frequently reassess appropriateness of the medications. Okay, when work when working with elderly patients, clinician often clinician often must mm, clinician often must manage multiple chronic conditions, cognitive impairment, hyperlipidemia, diabetes in patients who are increased risk of adverse drug events. To appropriately manage these conditions while minimizing the adverse drug event, clinicians should individualize drug therapy to each patient's context and therapeutic priorities. Prescription for elderly patients should consider the medication, magnitude of the effect, and the time of the therapeutic benefit. In addition to the patient's goal of the care and health status, life expectancy. For example, treatment of the systolic blood pressure 140 or 159 is associated with 2% absolute risk reduction in coronary artery event over 4 to 5 years. This information may support this information may support starting antihypertensive therapy in some patients has therapeutic goal and patients has therapeutic goals, good health status, longer life expectancy, but not others. Frail elderly patient with primarily palliative goals of care and short life expectancy. Similar factors should be discussed with the patient when recommending the optimal treatment for hyperlipidemia and osteoporosis. What does it mean? I didn't get it.
I think they're trying to say that, like, what's the point of giving somebody a medication that's gonna um, help them in 3 to 5 years, but the person is gonna die in 1 month. So you're giving a medication that's gonna have effect and let have effect in like 3 to 4 years or something, but the patient only has like 1 year to live, and they are really old, they're like 90 with all these conditions, and you the medication is going to take 3 to 4 years to work, but the patient is dying in 2 months. So what's the point of starting that medication? I think that's what they're saying. Does it
Okay.
make sense?
Yes. Is there anything written that this patient will die within 2 months like that?
No, I think they're saying that because she has a malcognitive, she has diabetes, she has hypertension, she has all, and she's 83.
Yes.
So yeah, so they're saying that even if you start hypertensive medication, um, the hypertensive medication is going to be beneficial in like 4 or 5 years. But I mean, she's 83 and she has like all these things. So
So
will she be really,
we should not give like we should not give burden or
yeah, don't burden her with a lot of medication because you have to start the hypertension, but you also have to give something
uh,
for the
lipid.
lipidemia, and you also have to give something for the glucose. So you're gonna start, and she's not taking any medication at all. So you're gonna start hitting 3 or 4 medications at the same time. Why?
Okay.
You know, like
Yes.
she's old, yeah. So go what is maybe start her in two, try to control the hypertension and the glucose, but leave the lipidemia, whatever. Basically, you have to talk to the patient and see what's worth it and what is not worth it. So I think that's what they say.
Okay.
Okay. 8-month-old previously healthy girl is hospitalized in the pediatric NICU for septic shock due to meningococcus. A right internal jugular central venous catheter is placed for hemodynamic monitoring and vasopressor administration. The patient received appropriate antibiotics, her condition improved, and daily lab results, including CBC electrolytes and GFR, returned to normal. Hospital day 4 after dressing change and catheter inspection. A provider flushes the catheter with low-dose heparin for routine care maintenance. Second later, the patient becomes cyanotic and tachypneic. Blood pressure is low, pulse is high, respiration high, oxygen sat 93. Pulmonary exam shows tachypnea with normal breath sounds. Pupils are equal and reactive. Which of the following is the cause of this patient presenting? Wait, is this ethics? Is the cause of the patient presentation? Hmm. Hmm. Edema, no more breath sounds.
Okay. This patient developed hypoxia, hypotension, tachypnea immediately following flushing, injecting a small volume of low concentration heparin or saline done to prevent catheter occlusion of her central venous catheter. The most likely cause is pulmonary embolism due to catheter-related thrombus. Presence of CVC catheter, presence of a central venous catheter, which is leading risk of venous thromboembolism in children. Central venous catheter is a thrombogenic because they introduce foreign material triggering the coagulation cascade, interfere with blood flow and cause intravascular or microtomas. Sudden symptom onset of central venous catheter manipulation, removal, flushing, reposition, which dislodge the thrombus from the catheter tip into the systemic circulation, which dislodge the and meningococcemia, which results in hypercoagulability due to activated protein C deficiency. In patients with pulmonary embolism, presentation may be in children with pulmonary embolism, presentation may be classic, may be classic, as in this patient, tachypnea, hypoxia, hypotension, or non-specific. A high index of suspicion of venous thromboembolism should be maintained when children with indwelling central venous catheter experience acute unexpected clinical deterioration, especially after the central venous catheter manipulation, heparin flashes and DVT prophylaxis with subcutaneous low molecular weight heparin do not prevent catheter-related thrombus. Insufficient evidence currently exists for use of systemic anticoagulation with heparin doses to prevent venous thromboembolism in children with central venous catheter. Okay,
Maybe D as in dog.
okay. Incorrect heparin administration, accidentally using high rather than low concentration to flush the CVC catheter can result in immediate catastrophic cerebral hemorrhage. This patient lacked signs of cerebral hemorrhage, seizure, vomiting, abnormal pupillary findings, and systemic bleeding from the catheter size. Her sudden onset, sudden tachypnea, hypoxia suggest a pulmonary etiology of her symptoms. For her symptoms.
Next. That didn't look like an ethics question. 55, 59-year-old man comes to the office for presenting visit. He feels well but has experienced an unexpected 5-pound weight loss in the last 2 months. The patient has a 45-year smoking history. Medical history is fine. Physical exam is normal. Fecal occult blood testing is positive, and colonoscopy is advised. So the patient has a colonoscopy. That sounds serious. Do you think I have cancer? Which of the following is the most appropriate response to this patient question?
Okay, counseling patients in clinical uncertainty. In the introduction, establish rapport and express concern, assess patient's knowledge and understanding, understanding current facts, and review established fact and explain differential diagnosis, individualize, clearly state the level of the uncertainty, plan of care, recommend plan to clarify diagnosis, test, specialty consultation, emphasize shared decision making, and arrange for follow up. This patient with this patient with significant smoking history has unexplained weight loss and a positive fecal local blood test, which together support which together suggest a possible malignancy in the colon. This presentation warrants further evaluation in colonoscopy, which should be completed in a timely manner. However, these patients' clinical features are not specific for malignancy and is significant uncertainty as to cause of her symptoms. Counseling of this patient should counseling this patient should include a clear statement that his symptoms could represent a serious condition. The conversation need not detail every possibility in the differential diagnosis, but the clinical suspicion should be explained in a way that patient can understand. The clinician should convey an appropriate sense of clinical uncertainty. In this particular case, the level of uncertainty is high, which should be expressed to the patient. The plan for diagnostic test and subsequent follow-up should be as clear and specific as possible. I can call you with test results on Monday. Finally, the patient should have adequate opportunity to ask questions and obtain clarification. Okay.
68 men with history of type 2 diabetes hospitalized with septic knee arthritis. Peripheral inserted central catheter is placed for administration of IV antibiotics. 7 days later, nodes redness and drainage around the patient's catheter insertion site. Blood cultures subsequently reveal gram-positive foci in clusters, and the catheter is removed. Which of the following recommendations is most effective in reducing risk of this? Which of the following recommendation is most effective in reducing risk of this complication?
Okay. Prevention of central line prevention prevention of central line associated bloodstream infection. Catheter insertion. Before catheter insertion, hand hygiene prior to use of gloves, full barrier precaution masks, sterile gloves, gown, wrap, preparation of skin with chlorhexidine solution, procedure performed by experienced provider. Catheter type and site. Catheter type and site. Use of PICC. Uh, so peripheral Catheter type and site: use of PICC, peripherally inserted central catheter, and tunnel catheter. For central venous catheter, use of subclavian and internal jugular venous catheter. Subclavian and internal jugular venous catheter.
The brother is worried the patient took something that caused him to become violent. On arrival, the patient attempts to push several staff members. He is given IV lorazepam and placed on involuntary hold for observation. Temperature is fine, BP is fine, pulse fine. Physical exam shows 4 centimeter laceration of the left forearm with no active bleeding. An hour later, the resident awakens the patient to examine the wound and recommend irrigation and closure. The patient refuses the procedure and says, I just need to stay for and I'll come back when I wake up. Which of the following is the most appropriate next step in management of this patient? Mm, mm, mm. It's a tricky question.
Very confusing option.
It's tricky because all the options make sense. Perform the procedure because the patient has capacity to refuse. No, I don't think he can access that.
After reading this type of option, I feel like kill myself.
Oh my goodness. They assist. Okay, maybe. Oh, jeez, that was confusing.
Okay. Mm, Although although this patient was placed on involuntary, although this patient was placed on an involuntary Although this patient was placed on an involuntary hold due to aggressive behavior, assumed it cannot be assumed that he lacks capacity to consent or refuse non-emergency medical treatment. The informed consent process must be conducted for all patients, including patients are being held involuntarily for substance intoxication or mental illness. Consent for a non-emergency surgical procedure or treatment must be given in voluntarily, and the discussion must include an explanation of the diagnosis and the risk and benefits of both proposed treatment and the treatment alternatives, including no treatment. Patient under involuntary status have the right to refuse treatment for an injury that is not life-threatening, and these patients' refusal should be respected. Because there are concerns for substance abuse, he received sedating medication, lorazepam. The possibility that drug effects temporarily influenced his ability or willingness to participate in an informed consent discussion should be considered. The procedure should be performed and the patient should be reassessed when the drug effects have subsided. Okay.
Okay, next. 65 men with history of obesity, aortic stenosis, coronary artery disease is undergoing combined valve repair and coronary artery bypass grafting. Okay. Multiple complications prolong the case by several hours. As the surgeon is preparing to complete the procedure, a scrub nurse is counting the number of sponges and instruments and notices the tip of a surgical suction catheter used to irrigate the chest cavity is missing. It brings this to the surgeon's attention and suggests the chest X-ray to be ordered prior to closing the wound. The surgeon disagrees and responds that the X-ray should be deferred until the case is complete. The postoperative film reveals the catheter inside the chest, necessitating the patient return to the operating room for retrieval. Which of the following intervention is most likely to prevent the root cause of this error? Which of the following intervention is most likely to prevent the root cause of this error? Okay.
Okay. Features of effective features of effective teams in healthcare: safety closer, resource commitment to safety, collaboration like shared understanding and prioritization of the goals, distinct role that avoid a steep hierarchy, psychological safety, asking questions and voicing concern encouraged, avoiding blame or retaliation, responsiveness, feedback respected and promptly acted upon, situational awareness, persistent mindfulness and safety vigilance, cross-checking of each other's actions, and transparency, prompt disclosure of errors, and safety information. Retained foreign objects (RFO), which are more common in prolonged surgery patients with biopsy constitute a sentinel event. Serious medical error resulting in irreversible patient harm. These nurse detected a missing catheter tip and suggested an appropriate action in a intraoperative X-ray. However, the surgeon's response prevented prompt assessment and prevention of the RFO. These interactions illustrate poor teamwork and communication leading root causes and system-level factors of sentinel events. Simulation training is a method of interactive group learning in which teams learn and practice skill together in a simulated cases. Suspected RFO during complex surgery, mm, it improves teamwork. It improves teamwork and is used frequently in high reliability organization, high risk industries with excellent safety records to promote safety. In the case, simulation training could address root cases of retained foreign objects by improving the team skills, responsiveness, collaboration, and situational awareness. Responsiveness: a nurse clearly asserting safety concerns, sergeant respecting and fully addressing the nurse concern, collaboration, sergeant and nurse sharing and prioritizing safety goals and demonstrating respectful communication, and situational awareness, sergeant and nurse both being aware of and vigilant threats to safety, written foreign objects. Prevention also necessitated conducting repeated counts of the sponges and instruments and manual reconciliation counts prior to completing surgery. However, relying on repetitive manual counts to prevent RFO is error prone, and in more than 80% of the written foreign objects, staff believe counts to be corrected and does not address the root case of poor teamwork. For example, repeating sponge and instrument counts would not prevent written foreign objects in the situation because a count discrepancy was already suspected and brought to the surgeon's attention and is incorrectly dismissed, reflecting poor team responsiveness and situational awareness. Okay.
Okay. Next. 16-year-old boy brought to office by his mom for follow up after sustaining a ligament injury while playing football 4 weeks ago. Ligament injury. The patient has been using a splint and going to physical therapy twice weekly. His pain has decreased and he's hoping to return to football practice. Pain has decreased and he's hoping to return to football practice. Okay. Medical history significant for asthma managed with as needed albuterol and prior treatment of gonorrhea, which he acquired a year earlier after an unprotected sexual encounter. Physical exam of the ankle reveals no pain, tenderness, swelling, and there is full range of motion. At the end of the visit, the mother mentions that the family is moving to a new neighborhood and will be changing medical provider.
Sorry.
You were not even using it anymore.
And they are shifting everything in the team.
To teams, yeah, yeah.
Yes.
I mean, they've been doing it for a while now. So yeah,
Sorry. They are.
they've been doing it like we switched to teams like a while ago. So they've
Yes.
been switching. Yeah,
I
yeah.
remember. Like we Skype was good, but I don't know the last days it create problems, but Skype was okay.
So
Better
is
than
the quality?
very better than yeah Discord.
Oh wait, is the quality better here on Teams or was it on Skype?
Mm, in the team there is lots of option than the Skype.
Oh, okay, okay. Guess that's good then. Okay. 3-year-old boy hospitalized in the pediatric NICU due to septic shock. The patient hospital course is complicated by central venous catheter, deep venous thrombosis in the right subclavian vein, and preparations are made for continuous infusion of IV heparin. The dose of heparin is calculated in units per kilogram and prepared for premixing from a premixed bag of IV heparin. Shortly after the infusion of heparin has started, the patient becomes unresponsive and cannot be resuscitated. Oh. The team discovered that an excessively high dose of heparin was given, resulting in overdose and massive cerebral bleeding. Hmm. Which of the following strategies is most likely to reduce future occurrences of this error? Hmm. Hmm.
Okay. Heparin administration is a high risk process. Heparin administration is a high risk process and often requiring manual preparation of infusion solution from a pre-mixed bag or vials, which may look like despite highly variable concentrate ranging from 1 to 20,000 unit per ml. Infusion protocol units per hour, ml per hour, units or kg per hour may differ even within the same hospital, necessitating dose conversion, increased risk of mathematical error. Human factors engineering reduces error risk by designing process responsive to expected human behaviors according to high according to human factor engineering hierarchy of effectiveness strategies that remove or greatly reduce human effort for correct action are most effective. Infusion pumps with dosing algorithms and preset limits. Smart pumps apply the most effective heparin human factors engineering strategies to reduce heparin associated errors. Computerized automation and forcing function and hard stops. Computerized automation replace human effort with technology to reduce harmful process variation. Dosing algorithm automates conversion between infusion protocol, preventing mathematical errors. Automation is appropriate for constant, predictable process. Constant heparin infusion on a hospital floor, but is less suitable for dynamic process requiring critical analysis and frequent adjustment. Administering heparin bowls in an operating room. Forcing functions are hard stops in a design or process that eliminate the risk of incorrect action. Pre-configured dose limits represent a hard stop blocking infusion of excessive heparin dose. Okay.
Can you read the box?
Okay. Yes. Uh, Heist, forcing functions, computerized automation environment. Forcing function is hard stops in design or process to eliminate risk of incorrect use. Example, each anesthesia gas fits only one compatible sockets and is not interchangeable. Computerized automation, automated process to remove human effort and variation that can cause error. Example, automated vital signs monitoring, an environment and physical layout, workplace design to facilitate correct action and minimize error. Example, look alike drugs stocked in different location. Example, look alike drugs stocked in different locations. And high is standardize and simplification uniform process to minimize variation complexity and and learning curve. Example, every hospital unit follows the same process for heparin administration. And high is human machine redundancy, repetitive step to confirm the correct action in an error prone process. Example, barcode scanning for medications in addition to visual inspection. And medium is reminder, alert, double checks. Process prompting providers to check action to reduce errors. Drug interaction alert, timeout before procedure. Okay.
Okay. Hospitalist who covers a cardiac ward in a tertiary care medical center noticed that hospital-based cardiologist with whom she has worked for several years is increasingly difficult to reach. The cardiologist now takes several hours to respond when his page while on call appears distracted and irritable during discussions and leaves his patient consult notes incomplete for longer than 2 days. The hospitalist has also noticed that the cardiologist has been rounding at 11 p.m. She once heard him mention a family emergency to one of the nurses. He has told the hospitalist that she can always call one of his partners as a backup if he does not answer pages. Um, the hospitalist has not noticed any medical errors made by the cardiologist. Which of the following is the most appropriate next step by the hospitalist? Hmm.
Should we report or should we inquire?
Hmm. But he hasn't done anything.
But it is not ethically right, like giving my work to throw it.
Oh, damn it.
Is it report, isn't it? Okay.
Yeah.
So you cannot give your duty to others, like you cannot throw your
Jeez.
duties. Sorry.
Jeez. That's
I- Is
okay.
this rules are written only for the exam?
That probably only for the exam because this doesn't make sense. You see it all the time. Like if one person doctor cannot do something, then the other comes and covers him. It's like normal.
Yes, people are backing up. Like
Yeah.
backup is everywhere. I don't know, and I don't think so. People give people like inform this sort of thing to the physician health program, because if like reporting done, then the consultant get
Mm-hmm.
negative point.
Mm-hmm.
Okay. The cardiologist behavior should raise concern for physician impairment. Physician's impairment. This is normal for me. Whenever the exam is coming, I got defined as impaired ability to practice medicine competently and safely. Signs of impairment including being increasingly difficult to reach, unusually late rounding times, decreased chart performance, and increased irritability and distractibility in clinical discussions. Deterioration in clinical performance is typically late sign indicative of more severe impairment. Physicians are ethically obligated to report suspected physician's impairment in the interest of physician safety, preventing medical error. This should be done regardless of other staff has expressed whether other staff has expressed similar concern or patient complaints have been filed. Reports are made by physician health programs, which are typically hospital-based organization designated to investigate reported concern and arrange for a comprehensive assessment of the physician to help to identify substance use or psychiatric medical illness. If there is no designated PHP, primary health physician, sorry, physician health program, the relevant chief of the service should be informed. So physician health program, PHP. Now, if not present, then relevant chief of the service. PHP are confidential resources that provides extensive support and expert education and monitoring. If the intervention is required, the PHP can assist the physician in getting necessary treatment. Recovery rates are much higher than the general population, including among physicians involuntarily referred to PHP who generally express satisfaction with their participation in the PHP. The majority of the PHP are independent from the state medical boards, although depending on the state, impaired physicians who choose not to follow PHP recommendation may be reported to the state medical board, given potential impact on public health and patient safety. Okay.
Okay. You want to take a break? A 5, 10 minute
Yes,
break.
yes.
Okay. See you soon. It's not a pep toxin. She has mild redness or of both eyes. Oropharyngeal exam shows enlarged erythematous tonsils were exuded. There is no lymphadenopathy. Lungs are clear. Abdomen is soft with no organomegaly. Skin exam shows multiple linear ecchymosis localized symmetrical on the child's back. The rest of the exam is fine. When asked about the skin findings, the mother says, I've been rubbing her back with a coin to remove the illness. It's part of our culture. In addition to providing appropriate care for the child respiratory illness, which of the following is the best next step?
Okay. What coining? Copying. Okay. Provide culturally competent care. Providing culturally competent care is important in fostering trust with patients from diverse cultural and religious background. These skills are developed through genuine respect for patients' cultures with a unwillingness to incorporate them into individual's care plan. In this care, this patient's mother performs quinine, a cultural originating from the China and Southeast Asia. A coin and other hard object is used repeatedly stroke lubricated skin, chest, back in linear symmetric fashion. The goal is to induce erythema, which later develops ecchymosis through which hit a negative energy and illness thought to be released from the body. Another common cultural practice is cupping, which is heated cup is applied to skin, creates suction, resulting in circular ecchymosis. These practices can be painful but usually carry little risk. Patients should generally not discouraged from coining, given its cultural root and limited adverse effect. In addition, patients should not be focused of child abuse or report the authorities because with Asian culture, the intent of coiling to alleviate illness, not to harm the child. Further management may include offering less painful alternatives like ibuprofen for fever and antibiotics if indicated. Okay.
Next. 27 Primigravida 18-week gestation comes to office for routine prenatal visit and anatomy ultrasound. The patient feels well, not concerned. She's accompanied by mom as her husband was unable to get out of work. The patient has no chronic medical condition, medication, prenatal vitamin. Ultrasound shows cephalic singleton fetus measuring less than 10% are consistent with severe growth restriction. There are bilateral choroid plexuses, clenched face, and a large BSD. Amniotic fluid level is normal. The placenta is posterior and frontal. Which of the following is the most appropriate initial statement by the physician?
Is it what is the diagnosis? Is it Prince Edward syndrome?
Um, I'm
VSB,
doing
clench fist, rocker bottom, isn't it? Or
probably,
patao.
yeah, probably fatal. Mm. The beta was suffered as you stable genetic abnormality. And let's schedule a follow visit to discuss also when your husband can be here with you. There are some things about your health or something that I need to discuss with you. Is it okay to do that now? Maybe okay, you want to schedule so we can talk about your results. Ah,
Okay, so it's Spike's protocol. Spike's protocol is like set the stage, perception, invitation, knowledge, empathy, and summary and strategy. The ultrasound, the ultrasound findings of severe growth restriction, the ultrasound findings of severe growth restrictions and bilateral choroid plexus cysts, clenched fists, and large ventricular septal defect are consistent with trisomy 18, the second most common autosomal trisomy, which results in fetal loss of neonatal death in the majority of the cases. In this case, the physician must deliver very serious news to a patient presenting for a routine visit who believed her pregnancy was normal. When serious news is unexpected, it is especially important to prepare the patient to determine how the patient would like to receive the result. The physician should provide a comfortable setting and ask the patient's permission to share the result. This allows the patient to respond with her preference and avoids making assumptions about whom, if anyone, she would like to be present. For example, some patients may prefer to defer discussion of the results until a major support person, husband, mother, is present. In addition to establishing the patient's preferred setting, the physician should determine how much information the patient would like to receive. Some patients may refer detailed medical information about the diagnosis and the prognosis, whereas others may prefer to process the news and emotionally before receiving further information. The Spikes protocol, setting the stage, perception, invitation, knowledge, empathy, and summary. Strategy is a six-step model that can guide physician in delivering serious news. Okay.
physician goes to labor and delivery on Friday evening to check on labor progression of a patient. The patient has had a protracted labor course throughout the day. Cervical dilation has increased 1 centimeter over 3 hours, and she's now 8 centimeters dilation. Vital signs normal, a fetal heart rate racing 1, category 1. The physician is leaving town for vacation in a few hours, but an on-call obstetrician will be available for later delivery. The current physician recommends performing a C-section now because of the protracted labor course and this physician's inability to attend. Okay, the current physician recommends performing C-section now because of the protracted labor course and this physician's inability to attend the delivery in a few hours. This situation demonstrates which of the following. Hmm.
Okay. The patient's active phase of labor has been protracted. However, her vital signs and heart rate tracing are reassuring. However, her vital signs and heart rate tracings are reassuring, and the vaginal delivery could still be possible if her contractions are optimized. Oxytocin augmentation. Although the current physician is leaving the town for vacation in few hours, there is still an on-call obstetrician available for later deliveries. Therefore, most appropriate management is to continue to labor for possible vaginal delivery even if the current physician cannot attend the delivery. Instead, this situation demonstrates a conflict of interest because current physician's recommendation cesarean delivery now is out of self-interest and personal convenience, expediting delivery prior leaving for vacation, thereby influencing or biasing the process of informed consent. Physicians are obligated to inform the patient of all medically reasonable alternatives, labor augmentation versus proceeding cesarean delivery, and to provide medical care that is most likely yield the greatest benefit to the patient regardless of personal interest. Okay.
Unit E.
Yes. Preventive ethics occurs when a consent process helps to anticipate and prevent future ethical issues. An example an example is obtaining informed consent at a routine obstetric visit for cesarean delivery rather than intrapartum when emergency decisions may be required. Okay.
During a particular busy winter season, the medical director of a primary care clinic implements a strategic plan to reduce um, iatrogenic transmission of our respiratory viruses among patients and staff within the clinic. As part of the plan, all clinic staff complete an in-service training on infection control and influenza vaccine counseling practices. Additional dispensers of hand sanitizer are installed in prominent high traffic areas, and an updated ventilation system is installed to improve air circulation. In addition, patients in the waiting room are provided masks if they are experiencing cough or fever, and an eligible patient and all eligible patients receive enhanced counseling and education materials promoting influenza vaccine administration. This strategic plan best presents which of the following approaches to increase safety.
Okay. This is Swiss cheese model.
Mhm.
Overlapping barriers to block safety hazard. Okay. The Swiss the Swiss cheese model is a strategy often used in healthcare organizations to increase safety. Swiss cheese model recommendations overlapping multiple barriers. Overlapping barriers, multiple barriers visualized as slice of cheese within a process to block hazard. Targeting hazards include block internal human error, mistakes resulting from fatigue or and external threat, infectious agent. Swiss cheese model is based on no single defensive barrier and washing is fully error proof and each intervention contains holes, vulnerabilities, forgetting to wash hand, incorrect hand washing technique that can enable an adverse outcome and transmission of infection. Harm occurs when hazards pass unchecked through the holes in defensive barrier and staking multiple overlapping slices or defensive barriers will increase the likelihood that hazards will be detected early. Downstream harm, adverse patient outcome will be blocked. In this clinic, overlapping barriers against virus transmission include intervention targeting human efforts, mask, hand hygiene, medical care, vaccination, and the physical environment ventilation system. These barriers, in combination, are more effective in reducing transmission of infection than each barrier alone.
Okay.
Okay.
Next. Hospital Quality Assurance Committee reviews data indicating a high prevalence of healthcare-associated infection caused by drug-resistant enteric pathogen within the hospital. These include diarrhea, illness, pneumonia, and UTI. Although the hospital has established standardized guidelines to prevent infection transmission that incorporate isolation precautions and hand hygiene, committee members are concerned about suboptimal adherence to health by healthcare workers. Which of the following action is most effective in improving staff adherence to recommended infection control practices? Name it.
Okay. Isolation precaution. Isolation precaution including contact, airborne, and droplet isolation are essential to preventing healthcare associated infection in patients in patient setting. However, suboptimal compliance with these protocols can occur in busy, complex settings, high patient volume, multiple demands on healthcare workers' time, compromising patient safety. According to principle of human factors engineering, process should be designed to minimize human effort required for correct action. Visual aids such as signs of patients such as signs of patient doors Specifying isolation precaution can increase adherence by doing the following: optimizing environmental design, sign out patient's room, convey relevant information to healthcare worker immediately prior to patient's contact, reducing reliance on memory, sign specific instruction needed for the protocol, and increasing attention through strategically placed alerts. Signs are brightly colored and placed selectively only when it. Can you explain?
Oh, um, they're saying that what they're saying. Oh, that if you place the sign, like for example, in front of this patient has TB, and you want to do a like TB is what airborne.
Yes,
I don't know, whatever airborne. Uh, Basically, they have to be isolated, and then if you go into the room, you need to wear the N95 mask, all of that. So let's say in front of the on the door of that patient room, you place like a red, big red sign that says airborne precaution or whatever. Even if the doctor was that was coming in was distracted, once he sees that big red sign at the door, he's going to stop him on the wait. Okay, red, that means a problem, or that that means this the patient has airborne, so I have to put the mask. So the sign is that you know it
okay,
made him realize. Okay, that's what they're saying. That those are good things. Can you read the box?
yes. Airborne bacterial TB, viral primary VZV, disseminated VZV, dermatomal VZV reactivation in immunocompromised patient, and COVID-19 and measles. Negative pressure room and N95 respirator contact is multi-drug resistance organism MRSA, VRE, ESBL producing. Bacterial is Clostridium difficile, E. coli 157H7. Viral is respiratory syncytial virus, primary varicella zoster virus, chickenpox, disseminated varicella zoster virus, dermatomal in immunocompromised. Contact is gloves, single-use equipment like stethoscope, and droplet is bacterial like Neisseria meningitis, Haemophilus influenza type B, Mycoplasma pneumoniae. Viral is influenza and adenovirus. Mask within 1 to 2 meter, 3 to 6 feet of the patient. Mask within 1 to 2 meter, 3 to 6 feet of the patient. And standard followed for all patients even no infection is apparent. Hand hygiene, gloves, gowns and gloves, mask when appropriate during procedure. Okay.
51 men comes to the office for follow-up appointment. The patient was recently diagnosed with ALS and his condition has gotten worse rapidly. Physical exam shows progressive muscle weakness and atrophy. The patient says, I need to know that when things get really bad and I can take care of myself, you will help me and end my life. I haven't discussed this with my wife yet, but I think she will agree that it will be better end my suffering when time comes. The patient has no psych history and is not currently suicidal. Which of the following is the most appropriate response to the patient request of consent?
Okay, you have been thinking about the end of your life. Okay, physician assisted suicide is the process that physician helps competent patient voluntarily end their life when faced with end of life suffering. It involves providing providing medications, a prescription or information to a patient with understanding that patient intends to use it to complete suicide. Although it is illegal in a few states, in some countries, physician-assisted suicide is controversial area of ethics. Physician-assisted suicide should be differentiated from euthanasia, in which physicians administer lethal substance. In the US, euthanasia is illegal and is considered unethical. When approached with such patient, physician respond with empathy and compassion to explore the reasons for the request. Reasons may include the fear of loss of autonomy, dignity, fears of suffering, uncontrollable pain, dyspnea, poor quality of life, feelings of not wanting to be a burden to others. Once the patient's fear and concerns are identified, the physician can discuss palliative care options that address specific issues. Palliative care intervention improve the quality of life, include adequate pain control, psychological support, comfort care, and appropriate multidisciplinary referral, hospice, counseling, and spiritual. Okay,
Okay, so basically, you can give him the medication to go kill himself, but you cannot, inject the medication on the patient to kill him. That's kind of
so
what that
what
means.
medication they give? Like opioid, like morphine high dose.
I guess, yeah. But the point is, you can give him whatever medication and he can go home and kill himself. But you yourself cannot inject the morphine on him. I think
Okay,
that's the key. Yeah. A medical resident on call is asked to see 72-year-old woman who has headache. Medical records indicates that she was admitted 5 days ago after a fall that caused a hip fracture, requiring surgical correction. The patient developed postoperative chest pain and was transferred to the medical service for further care. She's stabilized and receiving morphine for her pain, but frequently calls nurses to say that she's uncomfortable. According to the nurse, the patient developed an intermittent headache earlier in the day that recurred an hour ago after the daughter called to say she will be unable to visit. When she sees the resident, the patient snaps. You look so young, I hope you know what you're doing. The resident asks a few questions about her headache, but she gives very little information. When the resident attempts to perform a basic physical exam, the patient yells, "Don't touch me. I'm going to complain to the hospital administrator about you because you have no idea how to properly deal with the patient." Which of the following is the most appropriate response? Hmm.
okay. This patient is irritable, angry, and verbally abusive to the resident physician, although the immediate cause of her anger is unclear. Her complicated medical course, general discomfort and pain and probable disappointment that her daughter did not visit are likely contributing to her distress. Although the situation is challenging, it is physician's responsibility to be non-defensive, diffuse the patient's anger, and attempt to preserve the physician-patient's relationship. Acknowledging the patient's distress, remain non-defensive, and asking open-ended questions regarding what is upsetting the patient are the best means of establishing an open dialogue. Professionalism should be maintained at all times, and the physician should not retaliate with defensive or negative comments, which will only worsen the situation. Okay,
Can you read A and B?
yes. Reminding the patient that she is in a teaching hospital and mentioning the lack of experience will likely further anger her, provide her additional opportunities to criticize her. And B is although patients have the right to file a complaint if it is satisfied with their care, suggesting this approach is situation where there is no evidence of poor treatment is inappropriate and does nothing to resolve the issue or improve the physician patient relation. Can we stop here?
Yeah, we can.
Okay,
See you tomorrow.
okay.